Welcome to today's program entitled Evaluating Novel Targeted Therapies in RA, Clinical and Cost Considerations for Achieving Treatment Goals. My name is Jeff Dunn. I am Vice President of Pharmacy for Magellan RX, and my co-presenter is Dr. Stanley Cohen, who is Clinical Professor, Department of Internal Medicine at UT Southwestern Medical Center, also co-director of the Division of Rheumatology at Presbyterian Hospital, and co-medical director at Metroplex Clinical Research Center in Dallas, Texas. This program is approved for 1 CME, CNE, CPE credit. After the program, you can download a PDF of the presentation. You'll find this under the Event Resources tab on the left side of your screen under the headshot. If you have any questions for either Dr. Cohen or myself throughout the program, please don't wait. Type those into the box, which is located in the lower left-hand corner of your screen, and we will address those questions in the order in which they are submitted during the last 10 minutes of the presentation. After the formal presentations and Q&A, you will be redirected back to the landing page to complete the post-test and evaluation. After you do this, you will then be able to download or print your certificate. This program is provided by North American Center for Continuing Medical Education, LLC, which is an HMP company. We would like to thank them for all of their support. This program is also supported by an educational grant from Gilead Sciences Incorporated, and we very much would like to thank them for that support as well. The learning objectives are as follows. By the end of the program, we should be able to describe the clinical, social, and economic burden of RA and its impact on planned populations, evaluate the current and emerging treatments, guidance, and evolving targeted strategies for the management of RA. We should be able to integrate new and emerging JAK inhibitors into informed plan and pharma decisions, and finally, implement strategies to reduce access barriers to safe, effective treatments for RA. A succinct overview of the managed care aspects of RA show that RA is complicated. It's associated with serious consequences and comorbidities. From an operational perspective, RA is part of a larger autoimmune formulary contracting category, and this complicates things a lot, and I'll talk more about that. But when we talk about RA, we also are factoring in psoriasis and the GI indications such as ulcerative colitis and Crohn's disease, and it makes the management and financial aspects of this category of RA very complicated. The drugs that we're going to be talking about are very expensive, and we've seen significant price increases over the years. And that's the number one category of spend under the specialty benefit, which we'll delve into here in a minute. There's also a need to ensure appropriate and cost-effective therapies are used and sequenced appropriately. And like I alluded to a minute ago, contracting issues exist. Unfortunately, we do not have RA contracts. We have autoimmune contracts, and the contracts are on the drug, not indication. So until we get indication-based contracting, again, this is very complicated, and we have to factor in all of the autoimmune disease states when we're making RA formulary decisions. RA is complicated, like we said, and its disease burden extends well beyond the joint. And we see down here, importantly, there are comorbid components of this, including psychosocial aspects, which include impaired quality of life, fatigue, depression, cognitive dysfunction, disability, and then there's also a link to cardiovascular disease, osteoporosis, lung disease, and cancer, which is a component of the disease itself, but also a potential adverse event of some of the drugs that we're going to be talking about. So this is all interrelated, though. It's circular on purpose. And so when we talk about the treatment approaches and the treatment paradigms, it really needs to be multifactorial. It can't just be narrow-focused on the silo of RA. Here are some statistics on the clinical burden of RA. It's estimated that about 0.5% to 1% of the U.S. population has rheumatoid arthritis. This accounts for about 2.9 million ambulatory care visits per year. And there are over 15,000 hospitalizations with RA every year, where RA is listed as the principal diagnosis, so that probably underestimates the prevalence because of coding issues. RA patients have a 5 times higher cardiovascular event rate versus the general population, and many RA patients are unable to work within 10 years of onset, so there is a very important impact on disability That's getting better now with the newer drugs and the biologics. If we go back 15, 20 years before the biologics, the disability was much worse than it is today. So that's been a great advancement. And then importantly, the mortality rate is 1.5 to 1.6 times higher in RA patients versus the general population. So RA has a huge clinical burden. RA also has significant economic burden. Here we see that obviously patients who have RA cost a lot more than patients who do not have RA. Now this is driven by a combination of a couple things: higher pharmacy costs, more office visits, more emergency care, and more inpatient stays. Now unfortunately, a lot of this is being driven by the pharmacy side of it, the pharmacy component, because again, these drugs are very effective, but they're very expensive, and we've seen a lot of price increases. Now, the total incremental expenditure of RA patients is estimated, or was estimated in 2012, to be over $22 billion. That's obviously going to be higher now, as we get closer to 2020. Again, given the higher cost of the drug component. Unfortunately, the cost of RA treatment increases over time as function declines. RA is a chronic, progressive, debilitative disease. Here we see the severity on the y-axis, the disease duration on the x-axis. So as time goes on, the severity obviously is worse, and that includes disability, inflammation, and radiographic scores. The medical resource utilization is highest in patients with highly active RA versus patients who have low disease activity. So we can see that here broken out by low disease activity, high disease activity, and patients in remission on the x-axis. So the goal here is to get the high disease activity patients into remission. Now, again, we're investing in expensive drug therapy, so we really need to control the disease to realize the financial investment and financial benefit of these therapies. As I mentioned, the RA treatment goals are multifactorial. They really should include maximizing the long-term health-related quality of life, controlling symptoms, preventing structural damage, normalizing function, and then improving and enhancing and maintaining social participation. Now, the third and fourth here, the prevention of structural damage and normalization of function, are really probably the ones that are most relevant to our managed care people on the phone, but all of these are extremely important to providers and to patients themselves. But these all should be taken into consideration whenever we're making a treatment decision for any of our members or patients. Subsequent RA treatment strategy should focus on early and aggressive treatment. We need to attenuate the inflammation or inflammatory component of this quickly, and then we need to find the right drug at the right time to the right patient. So this includes treating to target, where the goal is to achieve minimal or no signs or symptoms of active inflammation, and then maintaining and achieving tight control, which is to minimize the level of disease activity over time through individualized therapy. And that's the disconnect, and one of the challenges is marrying this idea of individualized therapy for all of our patients with the formulary concept, which is a population tool. And unfortunately, we don't have thousands of different formularies, so we need to find that balance of doing the right thing for the majority of our patients, but having exceptions for patients who need individualized decision making. And this involves continually reevaluation. And this really is, we're making smart investments in these expensive medications. Digging deeper, early and aggressive treatment elicits greater disease control. And here we see, again, the percent of patients on the y-axis and the disease activity broken out on the x-axis with low disease activity and remission. And here we see that there is, and this data comes from 4 early TNF methotrexate studies, and those studies reported that a higher proportion of patients with very early RA achieved low disease activity and remission when treated more aggressively. So, I think a lot of us get a little panicked because of the cost of these medications, but the data shows that if we treat aggressively and treat early, then the long-term clinical and financial benefits follow that. So treating to target is this concept, and it really improves remission rates. And this data comes from the TACORA study, which stands for Tight Control of Rheumatoid Arthritis. And here we see that patients who are treated to target with aggressive early therapy receive much higher ACR scores and remission scores than those who did not. So if you look at the right here, remission is an example. If we treat intensively and aggressively and early, 65% of patients achieve remission versus only 16% with routine treatment with periodic follow-up and evaluation. So it's important that we close the loop and that the provider and the payer is on the same page, and we're working collectively together to make sure that these patients are actively and aggressively managed. We have many effective drugs to treat RA. We know a lot about RA. So the question is, why aren't more patients in remission? And unfortunately, there exist many barriers to RA disease control. Again, this is, like we said, is multifactorial, like the disease itself. So interestingly, no adjustment in RA therapy, despite documented high or moderate disease activity, often occurs. And this may be due to irreversible joint damage being done, patient-driven preference for current therapy, so they may feel invested in a certain therapy and be resistant to change to maybe a drug that would be more effective. Insufficient time to assess the effect of a therapy. On the flip side of that, sometimes we're making changes before we actually know if a drug is going to work. There are some safety concerns with some of these drugs, which include, like we saw earlier, it can include things like infection and cancer. The presence of comorbid conditions makes it harder to manage. These are complex patients, and there's usually a lot of drugs on board and a lot of physicians involved, and that makes the management a little bit more complex. And then this is a resistant disease in the sense that it's chronic and progressive, and there is no cure. The guiding principles of pharmacologic management of RA include constant surveillance, education, and adjustment. So the duration of therapeutic response varies among patients. Long-term RA treatment often involves a sequence of different therapies, and the optimal sequencing determined by response to therapy, disease progression, and effect of different therapies on disease pathways is the ultimate goal. So we have to, again, through our formulary, make the right formulary cost-effective value decisions, but we have to marry that with the care management individualized component to make sure that we are sequencing and making the right decisions for patients as they progress along the spectrum of RA. But this is all important to talk about, but here is, in my mind, one of the key issues. And this slide comes from the Express Scripts 2018 Drug Trend Report, and it shows that inflammatory conditions, which includes RA, but again, all of the indications that these drugs have, is the #1 category of spend under the specialty pharmacy benefit by a long shot. So two things I want to point out here on this slide. The first is if you look at the x-axis, this is dollars in PMPM per year. And we see here that inflammatory conditions account for almost $160 PMPM. So that means if I provide insurance for 2 million people, every single one of those 2 million people, $160 of their premium goes to paying for these drugs every single year. So it's a massive cost category for every payer. The second thing I want to point out is the last column, which is trend. And this has actually slowed. If you look back over the last 5 to 10 years, we've seen 20, 30, 40% year-over-year increases in the cost of this category. Now, in 2018, it was about 14%. That includes both increased utilization, but also price increases. So that far outpaces the general increase in cost in general. So this is a very, very important category for a lot of reasons. So with that, I will now turn it over to Dr. Cohen, who will talk about the current and emerging treatment guidance and evolving targeted therapies. Dr. Cohen.
Thank you, Dr. Dunn. We have made tremendous strides in the management of patients with rheumatoid arthritis since the introduction of biologics in 1998. However, clinical trials programs have demonstrated that biologics are ineffective in up to 40 to 50% of patients treated. Real-world experience, observational registries suggest that we're having to cycle through therapies to maintain clinical benefit, and many patients are having to switch therapy over short periods of time, 12 to 24 months. Multiple studies have demonstrated that sustained remission is very uncommon in less than 10% of patients. We have no treatment biomarkers to help us dictate therapy and determine which patients might benefit by one therapy over another, so our therapeutic trials are purely empiric. We have fortunately identified the adverse event profile of these therapies, but in patients with multiple comorbidities, this might limit the utilization of these biologic therapies due to risk of complications such as serious infections or bone marrow suppression or so forth. Over the last 2.5 decades, the various signaling pathways have been delineated and have demonstrated the various kinase proteins that are involved after a ligand binding to the receptor on the cell surface, resulting in transmission of signal to the nucleus, RNA production, and production of inflammatory cytokine, inflammatory proteins involved in rheumatoid arthritis and other autoimmune diseases. For many years, we worked on the P38 MAP kinase pathway and spleen tyrosine kinase pathway, and due to limited benefit and toxicity, those did not move forward. PI3K has been evaluated with limited efficacy in rheumatoid arthritis, although available in oncology, and FKA beta has not been evaluated yet in patients with RA, although preclinical models have suggested benefit. But the JAK-STAT pathway, Janus kinase pathway, has been utilized and will present a great deal of that data that led to approval of now 3 JAK inhibitors. Another potential target which is being looked at presently in clinical trials is the Bruton tyrosine kinase pathway. BTK is a pivotal protein in B-cell receptor signaling, and it also plays a role in Fc gamma receptor signaling in myeloid cells, and therefore is an ideal target not only for rheumatoid arthritis to downregulate autoantibody production, antigen presentation, but also cytokine production, but is also a potential target in lupus and related autoimmune diseases. There are over 90 protein tyrosine kinases identified. There's receptor PTKs, platelet-derived growth factor, epidermal growth factor receptor, and there are multiple non-receptor PTKs, including the Janus kinase pathway. Multiple therapies that inhibit protein tyrosine kinases are available in oncology and preceded the development in rheumatology. Shown here is a depiction of the various isoforms of the Janus JAK family. So there's 4 isoforms, JAK1, JAK2, JAK3, and TYK2, who then will autophosphorylate or phosphorylate downstream STAT family members, STAT1 through STAT6. 7 of those proteins are, again, targets for the Janus kinase molecules. It's important to know that the JAKs signal in pairs. So you need at least 2 JAKs to phosphorylate the STAT proteins, and we have been able over the last many years to identify the various cytokines that are involved in particular pathways. So for those with JAK1 and JAK3, which has a gamma chain which associates with those particular JAK molecules, IL-2, 4, 7, 9, 15, and 21 signal through JAK1, JAK3, gamma interferon through JAK1 and JAK2, as well as IL-6 through JAK1, which is very important in inflammation, IL-12, 23, and JAK2, TYK2, and again the JAK2 pathway, looking at JAK2 with JAK2, that's where erythropoietin and thrombopoietin will signal through there. And originally, when these molecules were identified, there was significant concerns raised about inhibiting JAK2, resulting in severe anemia, and the various animal models knocking out JAK2 and JAK1 were lethal, so there was a lot of concern if these molecules could be effective in humans, and indeed they have turned out to do so. Because of the different cytokines that bind to different receptors and utilize different JAK molecules, there have been attempts to develop preferential JAK3, JAK1 inhibitors like Tofacitinib or Filgotinib and Upadacitinib, which are more JAK1 inhibitors. Baricitinib was a JAK1, JAK2 inhibitor. And shown here is preclinical work we're not going to go into. There's enzyme assays, whole blood assays where you can demonstrate differences in Janus kinase inhibition. To date, however, in the clinical efficacy and safety of these molecules, this has not translated into clinical results. So even though this is very interesting and there may be subtle differences between the inhibitors of the JAKs, it really has not made a difference in clinical efficacy or safety. Shown here, we now have 3 approved JAK inhibitors. Tofacitinib was approved in 2012, baricitinib in 2018, Upadacitinib recently approved in 2019. Tofacitinib is approved not only for RA but psoriatic arthritis and ulcerative colitis. You can see on this slide all the other indications which are being evaluated for these inhibitors. Filgotinib, which is felt to be a preferential JAK1 preclinically, is wrapping up their development in rheumatoid arthritis, and you can see the diseases it's being utilized for as well. Again, there's subtle differences in the PK/PD. These drugs all have a very rapid onset, short half-life, and most of these, except for filgotinib, are metabolized by the cytochrome P450 system, which does need to have some concerns about other drug interactions like ketoconazole and rifampin. Tofacitinib is primarily excreted by the liver and 30% by the kidney. Baricitinib is primarily kidney and therefore potentially need to reduce the dose. And this says 4 milligrams here, which is the dose which is approved worldwide, along with the 2 milligram dose, but only in North America baricitinib is approved at the 2 milligram dose and only in TNF failures, where these other therapies are all the upadacitinib and tofacitinib are approved in methotrexate incomplete responders. Filgotinib, we're assuming, will be approved in methotrexate incomplete responders as well, and has 2 doses, and we're waiting to see if they will go to the FDA with both doses or just 1 dose. Upadacitinib also is only approved at the 15 milligram dose. The 30 milligram dose was not more effective and had more toxicity. This is a depiction of the clinical trial program for tofacitinib, and this is identical to all of the programs that have been done so far for all of the JAK inhibitors that are approved or awaiting approval. Patients were looked at who were methotrexate incomplete responders or DMARD incomplete responders or methotrexate incomplete responders with an active control such as adalimumab. And then there were shorter studies looking at TNF incomplete responders and also looking at patients who were no longer on DMARDs where it was given as monotherapy. This looks across the whole clinical trial program, and what we have on the y-axis is the ACR 50 response with the various studies. The purple is placebo and 5 milligram tofacitinib, which was the approved dose, 10 milligram dose BID, which was not approved, and here on the standard study you can see adalimumab in yellow, and you can see statistically different and superior response for both doses of tofacitinib as well as adalimumab compared to placebo. And these first 3 studies on the left are with background methotrexate. The STEP study also was background methotrexate with biologic therapy. Monotherapy is the solo study shown here. So significant ACR 50 responses. With all of these therapies, the response is rapid. You can see here, looking at the percent of patients with an ACR 20 response at 1 month was approaching 40-50%, and at 2 weeks was 20 to 30% compared to placebo. So this is one of the key features of these JAK inhibitors is a rapid response. And if you have a patient who hasn't responded by 8 weeks of therapy, the patient is most likely not going to respond. Radiographic studies were part of the clinical trial program for all of the JAK inhibitors. Shown here, tofacitinib 10 milligram BID was statistically different from placebo in the primary analysis. There was a trend for the 5 milligram dose here. These studies are very hard to do because of patient dropouts and the way statistical analysis is done and have a lot of issues with them. When looking at the high likely progressors of radiographic progression, you can see that both doses were protective against radiographic progression. And then a subsequent study looking at early rheumatoid arthritis where patients received tofacitinib 5 milligrams BID monotherapy or tofacitinib 10 milligrams BID monotherapy or just methotrexate monotherapy, and the co-primary endpoint was an ACR 50 response, and tofacitinib was statistically superior, as you can see, 47%, 56% compared to 27%, but also was protective as far as structural progression compared to methotrexate monotherapy. This is the baricitinib program, essentially the same clinical trial study design, early RA, methotrexate incomplete responders, biologic incomplete responders. This is the clinical trial data from the methotrexate incomplete responders, and again, 4 milligram baricitinib in the darker brownish color, the adalimumab in the yellowish color. Both were statistically superior to placebo at week 24, and you can see ACR 50 and ACR 70, where baricitinib plus methotrexate was superior to continuing methotrexate alone. Looking at radiographic progression, again, baricitinib and adalimumab overlapped each other, and look at this as a probability plot. You can see that more than 70 to 80% of patients did not progress their radiographs, and with baricitinib, it was 79 to 80% compared to 70% on methotrexate alone. So this demonstrates a statistical superiority as far as blunting radiographic progression. Then I wanted to show this one slide. This is 2 milligrams versus 4 milligrams of baricitinib. The U.S. FDA did not approve the 4 milligram dose of baricitinib because they felt, based on their review, that the 2 milligram dose was as effective and that the side effect profile may be somewhat more problematic with the 4 milligram dose. However, the 4 milligram dose is approved everywhere in the world but the United States and is actually the #1 JAK inhibitor being prescribed ex-US. So we will learn a lot of data in the real world scenario about how that dose works and what the true safety profile is in a larger number of patients. Again, finally, early RA, both baricitinib monotherapy and baricitinib plus methotrexate were statistically superior to placebo. Here, looking at ACR responses, ACR 20, 50, and 70 over 24 and 52 weeks. Upadacitinib, again, just as you can see here, methotrexate naive, conventional synthetic DMARD naive, and biologic DMARD incomplete responders, and the clinical trial program that led to registration. One study is still ongoing, and that's abatacept versus upadacitinib. This is an interesting study where the patients were with active rheumatoid arthritis, inadequate response to methotrexate, came in and received upadacitinib monotherapy, 15 or 30 milligrams, or continued their methotrexate through week 14. The primary endpoint was the ACR 20 or DAS28 CRP less than or equal to 3.2. And what they found is even with withdrawing methotrexate, which we've always been concerned about doing in the past, the patients did not flare, and they had a very, very good response, 68 and 71% ACR 20 response to compare to 41% of patients continuing methotrexate, and looking at DAS low disease activity was statistically superior to methotrexate as well. Notice again there was not much difference in the 15 and 30 milligram dosage of upadacitinib. Again, another study looking at conventional synthetic DMARDs, statistically significantly different with UPA at both doses, but again I want to point out this very rapid response in the middle slides here, looking at the rate of response over time in patients looking at ACR 20 and ACR 70. Finally, the filgotinib program. Again, this is ideal to the same exact design as we've seen with the other protocols. FINCH 1 was their study looking at filgotinib 200 or filgotinib 100 milligrams plus methotrexate compared to adalimumab plus methotrexate. At the end of 24 weeks, patients could be re-randomized to filgotinib plus methotrexate if they were on placebo. Bottom line, both doses of filgotinib plus methotrexate were superior to placebo and similar to adalimumab, shown here in yellow, at week 24 and at week 12. Rapid response that was sustained. This is another study looking at early RA, looking at 100 milligrams of filgotinib plus methotrexate, 200 milligrams of filgotinib plus methotrexate, or filgotinib monotherapy compared to methotrexate in purple. And what you can see that over 24 weeks, as similar to what we saw with baricitinib and tofacitinib and upadacitinib, filgotinib in combination therapy was superior to methotrexate. At week 24, the monotherapy did not quite achieve superiority, but this was primarily due to this very, very high placebo response seen in this particular study. If you take a look at more robust response criteria such as DAS28 CRP of remission or CDI remission or SDI remission or Boolean remission, you can see that even the monotherapy dose in blue here was superior to placebo, which was the methotrexate arm. Radiographic progression here, looking at the modified total Sharp score, again, filgotinib plus methotrexate or filgotinib monotherapy was superior to methotrexate alone and prevented radiographic progression. So there's a lot of interest in these new targeted synthetic DMARDs. Their utilization is increasing rapidly. There's been interest in monotherapy because we know that even with biologic therapies, 1 in 3 RA patients are using monotherapy. We often see patients who come into us and tell us that they're no longer using their methotrexate. They've stopped it on their own and they feel fine without it. So what is the data? This is a compilation of the Tofacitinib studies. The one on the left here is the oral start study, which was methotrexate in purple compared to 5 and 10 milligrams of tofacitinib in hatched bars here. Again, monotherapy. The oral strategy study compared methotrexate monotherapy to tofacitinib monotherapy compared to tofacitinib plus methotrexate at 2 different doses and showed that monotherapy was almost as effective as the combination therapy, not quite. And then the solo study, again, monotherapy compared to placebo was superior. We did a study just recently published in Lancet Rheumatology, where we took people who, after 6 months on tofacitinib plus methotrexate, were blindly randomized to withdrawing methotrexate or continuing methotrexate. And what we showed at the end of another 6 months was that monotherapy was non-inferior to combination therapy at the end of 6 months, shown on the graph here on the right, looking at the delta of the DAS28 ESR. So again, suggesting that patients in very low disease activity who are doing well with a targeted synthetic DMARD JAK inhibitor could withdraw their methotrexate and continue to do well. This next slide is looking at survival curves, Kaplan-Meier survival plot in an observational registry. And what I want to point out is that the bottom part of the slide, you're looking at TNF inhibitors, and you can see that monotherapy had lower rate of survival than the lighter purple, which is combination therapy. But the top of the slide, where you're looking at blue and lighter blue, is tofacitinib, and it doesn't seem to make any difference if you're on combination therapy or monotherapy as far as survival over 3 years, suggesting that it may be partly due to the anti-drug antibodies we see with our TNF inhibitors. So to finish up, let's briefly go over safety. We now have a very well delineated profile of the safety issues with JAK inhibitors. Like biologics, there's an increased risk of serious infectious episodes. We need to screen and treat and prevent TB. There's a slightly higher likelihood of hyperlipidemia, as now we recognize with all biologics as well as targeted synthetic DMARDs, which is not translating into an increased cardiovascular risk. We need to monitor the liver, especially in patients on methotrexate. Rare 1 in 1,000 GI perforations, possibly related to the IL-6 inhibition through IL-1. And then there's a question of increased risk of VTEs, venous thromboembolic events, and pulmonary embolism. Shown here is data from the FDA presentation for the advisory board for tofacitinib. On the x-axis, you can see the various adverse events of interest for all of our therapies. The circles are from published randomized clinical trials. The TOFA data for 5 and 10 are the light blue circle in the box. And what you can see is the rate of all-cause mortality, serious infections, malignancy, lymphoma, lung cancer, MI, and GI perforations is no different for tofacitinib, and this mirrors the data we've seen with all the JAK inhibitors. There's so far been no difference in the safety data for the 3 approved JAK inhibitors. There is one outlier, which is the risk of herpes zoster. That is definitely increased with at least the 3 approved JAK inhibitors, and we're awaiting on data with filgotinib. Baricitinib, just to point out to you, the risk of zoster was increased. This is from their integrated safety database. But what they had a very peculiar thing which raised an issue, and that was in their randomized clinical trial portion, placebo portion of their trials, they had 5 DVTs or pulmonary embolism compared to none in placebo. So the Bari 4 milligram had 5 DVTs or PEs. This led the FDA not to approve the 4 milligram dose and give them a boxed warning. Recently with tofacitinib, in a study looking at patients at high risk for cardiovascular disease compared to Enbrel or adalimumab, there was increased risk of VTs and pulmonary embolism reported with the higher non-approved dose, the 10 milligram BID dose. But again, this suggests that there may be a class effect of these molecules that may be associated with increased risk of venous thromboembolism or PE. And we don't understand the mechanism of action or why this is occurring. But for now, I think in patients who've had a previous DVT or pulmonary embolism or hypercoagulable, the JAK inhibitors, which should probably be avoided as therapy since we have so many other options. Laboratory abnormalities that can be seen are shown here. We monitor for these. Patients will have laboratory every 3 months, and certainly we need to modify the dose if neutropenia occurs or lymphopenia. The LFT abnormalities, by modifying the dose, can be easily managed. So to conclude, the presently approved JAK inhibitors have similar efficacy and safety. Filgotinib, we're waiting their integrated safety analysis. Will it have a similar safety profile or will it be different? If a patient fails one JAK inhibitor, will they respond to a second JAK inhibitor? This question was not evaluated in clinical trials. It's now being evaluated in the clinic as patients who have failed one are now being treated with the second one. So we should eventually have an answer to this question, and I expect the answer will be yes. JAK inhibitor monotherapy is effective. We're seeing a trend towards more JAK inhibitor monotherapy and now seeing clinical trial data, which I pointed out to you. Should JAK inhibitors be avoided in patients with previous VTs and PEs? That's my opinion. Again, the data is not clear, and we don't understand why this is occurring. We don't understand the mechanism of this. And again, we've shown you several trials with methotrexate and early RA comparison to the JAK inhibitors. JAK inhibitors were all superior to methotrexate. So why don't we utilize this treatment? Right now, we're prevented in general by step edits and block, because of the cost of these drugs compared to methotrexate. But it's something I think we need to continue to look at in particular patients who might need more aggressive therapy. So to conclude, the introduction of targeted biologic therapies has dramatically improved the quality of life and physical function of patients with RA. This has allowed clinicians to target LDA or remission as an outcome. However, even with this improvement, less than 50% of people achieve a 50% ACR response, and less than 10 to 20% achieve remission, which is rarely long-term. Having a number of therapies has allowed us to cycle through treatment to maintain low disease activity or remission, and biosimilars are also now available, certainly more across the pond in Europe and the rest of the world, where they substantially lower costs. We await the introduction in the marketplace here and see if this has some impact on cost of members in insurance plans or improves access to our patients. We need and want continued development of newer novel therapies to achieve our goal of sustained remission. I'll turn this back over to Dr. Dunn.
Thank you, Dr. Cohen. Obviously, as we've seen, this is a very complicated area with a lot of data and a lot of drugs, and that was a great overview. Appreciate that. So I'm now going to address some of the strategies that we can employ to reduce access barriers. I mentioned earlier, I touched on the fact that there are some barriers to treatment in this particular area, but the follow-on question to that is, why don't patients receive the best treatment? The question there is, how do we define best? And that's difficult, and some of the reasons for that include that not every patient is the same. There are presence of comorbidities. Patients don't always fit the trial design. Variation in study design. So with some of the newer agents and some of the affiliated disease states, we are starting to see more comparative head-to-head data. But we don't have a ton of head-to-head data. And studies that are done this year versus 15 years ago are very different. The patient population is very different, so it makes it much more difficult to make indirect comparisons. And then importantly, the health reimbursement system is an issue. There are misaligned incentives, like I mentioned earlier, around the cost of these drugs and the outsized role of contracts and rebates. And it's really hard to move against the older incumbent drugs that may not always be the most effective because of the large economic impact to the system and to clients of the rebates. But we do, despite all this, we do need to make cost-effective comparisons. Unfortunately, when we're making formulary decisions, we're relying on incomplete data. There is a general lack of head-to-head comparisons, which leads us to make other financial type decisions. But if effectively used, comparative effectiveness research can help fill some of those gaps. And I'll walk through a little bit of what CER is and how we have used it. So CER, if done effectively and appropriately and correctly, can change outcomes and can change practice. So CER establishes parameters to measure improvements by defining what the appropriate outcomes are, what the reduction in costs we're looking at, and subsequently, when we combine outcomes and cost, what the comparative value of these agents are. It also determines the threshold of positive effect to alter behavior to all of the respective stakeholders. And so that includes patients, providers, and payers. And unfortunately, the system is set up to basically silo those different stakeholders. But if we use a CER approach, we can eliminate some of those siloing issues. RA, in fact, is a prime target for this concept of comparative effectiveness research because it has a huge budget impact, as we see here on the y-axis, which we've talked about. It's the #1 specialty category in terms of spend, and we have a lot of agents on the y-axis. The number of comparable alternatives now is growing, and we have multiple options now. So if you combine those two things, it really is a perfect prime candidate for applying cost-effectiveness research. So other definitions of CER include value or cost effectiveness. Really, it's outcomes divided by cost. So we take the efficacy divided by the price. And a good way of how we employ or use this value proposition is this quadrant on the right. If you look at the top left, if a drug is less effective and more costly, it's obviously a clear loser. The bottom right, if an intervention is more effective and less expensive, then it should be a clear winner. The challenge becomes the other two quadrants. If a drug is more effective and more costly, what do we do? Alternatively, if a drug is less effective but considerably less costly, what do we do with that? And that's where formularies play a role, and that's where cost effectiveness plays a role. So if we do this, what we should be looking at is the cost per outcome. So in this particular situation, it's cost per event avoided, it's cost per ACR improvement, and that's a way for us to really address the issue of not having head-to-head studies. It's not scientific, and it's indirect, but at least it's a better way of doing it than some of the other ways of doing indirect comparisons. So specifically, here is an example of kind of a high level how to walk through this. So we really could be looking at studies that have similar design, similar inclusion-exclusion criteria. We look at the difference between the drug and placebo or the drug and alternative. We take that delta and we divide into that the net cost per drug, whether per month or per year. You have to kind of marry that and match that up to the outcome measure. And that approach gives us a cost per outcome. And then we can then make more of a tabular comparison among the different agents. Now, but the important thing here is that, we really also need to be holding, the industry accountable a little bit. And that's where some of the disconnect is the FDA doesn't require comparative studies. And so the pharmaceutical companies have to do certain studies to get the drug approved. So it's not necessarily their fault, but we do need to all collectively work a little bit better on how we can make, better comparisons. This approach was applied to the JAK inhibitors early. And here, this comes from a publication by Lee and colleagues. And it was the early data around cost effectiveness of JAKs as first-line therapy. So Lee and colleagues compared the anti-TNF agents to an oral JAK inhibitor, and they applied cost utility analysis and reported that in the oral study. Here are the results. So Lee and colleagues reported that first-line use of oral JAK inhibitors increased the quality-adjusted life years gained versus standard of care, resulting in an ICER of $13,000 per quality-adjusted life year. They also found that JAKs were also cost-effective not only in first-line use, but also in second, third, and fourth-line therapy. JAK inhibitor-associated increases in costs were attributable to the increased lifetime drug costs. They also employed a sensitivity analysis, and the ICERs were between $6,000 and $32,000 per quality-adjusted life year, so well within the range of cost-effectiveness. And from a societal perspective, the inclusion of a oral JAK inhibitor as a treatment strategy for moderate to severe RA is cost effective. But there's more to come. We still do need better guidelines, and we do need to address the issues that both Dr. Cohen and I have talked about some of the other misaligned incentives on why we don't have more open access to more different MOAs. The high drug costs can be somewhat effectively managed by aligning some of the different silos, which includes distribution, plan design, and pharmacy care management. It also includes IT, support tools, incentives, and copay assistance, how we apply those. This is presented in a cogwheel manner on purpose, and so it really all goes together, and they all need to work together to get the output of better outcomes and at a lower cost. And if all these things aren't working together, then we're going to have problems. So the point of this is we need to stop working in silos, and and that includes financial and clinical silos, but also stakeholder silos. So, if we, are working on a formulary strategy, we really have to have some buy-in from providers and vice versa. If there's, better approaches to doing something, then we have to be open to making some different formulary decisions. And we have to stop the reliance on this anchor, the rebate anchor that holds us down from making appropriate clinical changes. So basic tenets of the specialty drug benefit are listed here. We know about this. So that includes utilization management, PA step therapy, preferred drug management, contracting, which is aggressively negotiating rebates to minimize the total net cost of this category, channel management, and care management. And I'll talk more about these here in a second. Channel management, high level, is just the how we pay for these things under the medical versus pharmacy benefit and how we utilize that. Specifically, though, the successful RA management, pharmacy management, requires finding the appropriate balance of drug dispensing, utilization management, coordination of care, contracting activities. And you'll notice this is what we call our compass, and it all evolves or revolves around this concept of specialty drug management. It also needs to go hand in hand with the traditional formulary approaches of benefit design, which includes tiering and copay versus coinsurance and all of those associated issues. Traditional benefit design is listed here. Historically, we've had a handful of tiers where we delineate between generic and brand and specialty, and a lot of that has been based off of copays. And we put less expensive medications in preferred brand tier, and we've only had one specialty tier. So that's, I think, a little bit of an antiquated approach. This next slide shows a better example, and this is where I think the industry is moving. And one of the take-homes, I think, is if if you're a payer, you're not talking about where you need to be in 2, 3, 4, 5 years in terms of a benefit design. You need to do that because it takes a little bit of time to change benefit designs. But here's more of a modern, updated concept of a formulary benefit. It includes, but it's not complicated. It just includes multiple specialty tiers and multiple generic tiers, similar to what we've done at brands. And it gives us more of an ability to incent people to use the most cost-effective medications. And it also sets us up a little bit to take advantage of better contracting and biosimilars in the future if they are more cost-effective. We need to put those in a place that is going to cost the patients less money. If we don't have a place to put them and we put them in the same tier with the same cap, copay or coinsurance as a brand, there's going to be very little incentive to take advantage of these less costly medications. We could talk about contracting forever, and I just put this on here because value-based contracting is something that is discussed a lot when we're talking about RA. It's difficult in this particular arena because we're trying to marry medical and pharmacy data, and we're trying to marry subjective, not well-defined outcomes, and so it makes it extremely difficult to do. So the traditional contracting, which is shown here on the left, which is flat volume or share-based, which is usually a very high number based on a limited number of first-line therapies, that's really hard to overcome because the numbers are so big and the impact to the bottom line of the payer organization is so big. It would be super nice if we could move towards a risk-based contract where if the drug didn't work, the manufacturer was paying us back the cost of the drug, or paying us back, the cost of a hospitalization or some associated cost with the failure of the drug. But again, the challenge there is that implies that we have really, really good data that is almost impossible to capture, and it's very complex to do. A key component of drug dispensing is, like I said, channel management. And the channel management also includes this other concept or affiliated concept of site of care optimization. And here's an example of infliximab, a site of care, where the cost of this just comes from internal data, so don't get tied up in the numbers, but the concept is probably consistent across most payer organizations. Whereas if infliximab is infused in a physician's office or by home care, the average cost is about $25,000. If it's but the ranges of the cost of infliximab in a hospital outpatient department, it ranges anywhere from $38,000 to $126,000. That doesn't make any sense to me. That the same drug can cost 5 times more than the drug in a different site of care. So we need to refocus, if we're not already, on site of care optimization to make sure that these drugs are dispensed and infused in the most cost-effective setting. Specialty care management is a huge issue given the cost of these drugs, and it really entails combining medication therapy management and disease management. So whenever these patients, or whenever we have a patient on these drugs that are very expensive, we really should be care managing them and basically doing a medication therapy management intervention on them. That includes integrating with care management, making sure that the drug is dispensed in the right arena, sure that they're on the right dose, making sure that the patient is adherent to medication, and that they are that education is continually redone. So patient engagement here is extremely important. What we've seen and what we've learned over the years is that we can't tell a patient what to do. They have to be part of the plan, and so continually re-educating them and engaging them will definitely drive outcomes. So actions of a successful care management program must include designing the workflow and integrating with care management, analyzing utilization to select targeted disease and disease states and drugs, and then training personnel. So the people who are talking to our patients have to be really experts in this particular area, and they need to know about the classes, the medications, and then the operational components like the channel management and site of care issues. One slide on biosimilars. Dr. Cohen alluded to it in his conclusion. We could talk about this for hours, but I want to point it out because I was skeptical for a little while on biosimilars, but I'm now a little bit more hopeful. But you can see here that this shows some of the potential patent losses of some of these drugs. But I want to point out here that we're not getting help here. They're due to litigation and settlements and other things. The branded lifespan of these drugs now has been extended well past when they should have been off of patent. So that's a problem. So that's a challenge, I think, to the FDA and whoever else is involved, that we need better pathways to get these drugs approved and on the market. The other things, though, that we need to address in order to make biosimilars successful are obviously cost. And this is unlike, let's say, an oncology biosimilar that we're now starting to see, where we don't have rebates. It's really easy to have new patients start through the biosimilar, and everybody saves money. The challenge is it's much more difficult in RA in this particular arena, though, autoimmune, because of the existing rebates. And the rebates are large. And so if we are to move towards a biosimilar, then we are violating contracts and we lose rebates, and it actually increases the cost of the system exponentially. So if we are to make biosimilars successful, obviously the cost is the number one issue, but the second largely important issue is interchangeability. And that's also where we need help with regulatory bodies, but also with providers. That if we can't move market share and can't change a patient from a brand to a biosimilar, then we're just going to end up costing everybody a ton more money. So hopefully biosimilars can help save money in the future, but this is a very, very unique category. So to conclude, RA requires lifelong treatment. It places a substantial economic burden on the entire healthcare system, on individual patients, and on society as a whole. The cost of the drugs to treat RA are very high, and they continue to grow rapidly. The impact of that, and now our health plan employer groups are asking to do some kind of crazy things to manage these costs. And and if we don't address this collectively, we're going to see riders and we're going to see exclusions. We're going to see all kinds of things that are long-term detrimental to the patient. So payers require better solutions, guidelines, treatment algorithms that help the formulary decision-making be better. So those are the issues. Here are the real issues that need to be addressed. Contracting is what's driving our formulary. So, we can't dance around that. It would be nice to have figure out some way that we can move towards indication-based formularies, indication-based contracting rather than indication-based formularies. So, a particular drug may be more cost-effective for RA, but less cost-effective for psoriasis. And right now, our contracts don't allow us to distinguish between those two disease states. The contract or the rebate is on the drug; it's not on the indication. So, one solution would be to leverage our formularies and our lives to move towards indication-based contracting, because the rebates right now are an anchor. And I'm off in the weeds a little bit, but as payers, we have to provide rebate guarantees to clients, and we don't win business if we don't have competitive rebate guarantees. And this particular category contributes to a large proportion of those rebate guarantees, and so we can't. And that's the anchor. That's the barrier we need to move away from. If we can't move away from that, then we're going to end up with older, less effective, but lower cost formularies. So in real conclusion, in real summary, RA is the number one spend under specialty by a long shot. Most of the total cost of care in this particular arena is driven by the drugs themselves, not the medical offsets. But having said that, strategies that we can utilize to mitigate some of these costs are multi-tier specialty formularies that allows us to leverage benefit design to get better pricing on these drugs. It also provides an incentive to the patient through out-of-pocket to use the more cost-effective medications. Contracting has to change. Channel management should be effectively employed, where we can move some of the, let's say, infused drugs to the pharmacy benefit and use specialty pharmacy rather than buy and bill. Care management and specialty pharmacy management, like I said, are extremely important. We're spending so much money on these patients that we should build care management programs that we're interacting with patients and making sure that they're using the drugs appropriately and they're using the right drugs so that we can save money. Biosimilars potentially play a role, but there's some inherent limitations based on cost and lack of interchangeability. So the key here is that stakeholders need to work together to break the rebate cycle and to drive the most cost-effective options. If we don't do that, and we continue to work in silos, and we're antagonistic to each other, then everyone, including the patient, is going to lose in the long run. So that concludes the formal presentations, and we will now move to the question and answer section of the presentation. Thank you.
So we have a couple minutes, so let's just jump right into the questions, and thank you to those who have submitted questions. I'm going to, for the sake of time, combine a couple of these, and the first one I'm going to direct to you, Dr. Cohen, and there's two parts to this. The first part is range of motion, and the second part is diet. Is there, what is the role of those two things in the treatment of RA, and then is it something we should be counseling about?
Well, it's certainly something that we receive questions about all the time. As far as range of motion, we're real proponents of exercise to maintain mobility, so we encourage our patients to do general range of motion exercises, isotonic or isometric type exercises to maintain mobility, with the one caveat is that if a patient does have an inflamed joint, with aggressive range of motion exercise, you could aggravate the inflammation. So, but in general, we want our patients to exercise to help with maintenance of mobility. But in this day and age with the therapies we have, that's not as big of a part of the treatment armamentarium as it has been in the past, because most of our patients have very little in the way of active disease if they're appropriately treated. As far as diet manipulation, although we would love to believe and hope that there is some data that really shows that diet can reduce inflammation, it's still controversial. We receive anecdotes all the time from patients who tell us they modify their diet, stop gluten, plant-based diet or whatever, and they felt better, which we applaud them for. But we don't really have any good, robust data from clinical trials to support that any particular dietary manipulation makes a difference. So we will support people trying anti-inflammatory diets of any nature, but we want them to do that along with their conventional therapy. We would not want them to go on their own way without pursuing appropriate therapy, which we know is very effective in close to 70% of patients with RA.
Great, thank you. There were several questions around biosimilars. Both Dr. Cohen and myself touched on those a little bit. We didn't go into a deep dive, but there were questions around the impact of biosimilars in this category, price points, and then a question around are there any guarantees that biosimilar prices will be much lower. And I will just say, in kind of lumping all those together, this we're about 10 years behind Europe. We only have a handful of biosimilars now, and typically what we've seen is the first one comes out at about a 10 or 15% discount, and then as others enter the market, the price comes down. And that's going to be great in categories like oncology, where we don't have contracts, and we can just focus on new starts and start new patients on the biosimilars, and then everybody will save money moving forward. This category is much more complicated. It's the most complicated contracting category that we have, and it's the most expensive category that we have under the pharmacy benefit. So the rebates are the issue, and we have, every payer on the phone has, whether directly or indirectly, has really large rebates in this space, and so a biosimilar is going to have to legitimately be 60, 70, 80% discount for it to even be worthwhile to go towards the biosimilars. But the other issue is we're going to have the mechanism in place to move market share quickly, because if I'm as a payer going to move to a biosimilar, I'm basically voiding the contracts I have, and I'm violating the contracts that I have. And if the market share stays with the originator, then the rebates go away, and the originator, the costs basically double. And so obviously the most important thing is how much less money the biosimilars are. But then the second huge issue that goes hand in hand with that is the ability to move market share. And that's going to be the biggest issue, because there's going to be some educational needs. There's going to be some physician hesitancy to switch somebody that's stable on a biologic to a biosimilar for cost reasons. But again, if we don't move market share literally within a quarter, we're going to end up costing ourselves millions and millions of dollars. So those are the biggest issues in this category. But again, we're working through things that we're, in an attempt to be as proactive as possible. Things like multiple specialty tiers. I talked about that. That's something you can look at in your organization. Education, because probably the biggest interesting way we frame this with the provider is, if somebody's been on one of these products for 10 years, they've probably been on 20 different products because of how the manufacturing's changed or whatnot. So it's not dissimilar from going from a reference product to a biosimilar, but we're going to have to work through that. So I'll stop with that at this point and just open up to Dr. Cohen. If you have any comments before we close around biosimilars.
No, I just totally agree with what you have to say. I mean, there has to be something that benefits the individual patient for them to be willing to consider switching from a therapy that's doing well for them to therapy that's less expensive. They have to gain some benefit as well.
Yeah, I think the biggest thing that would fundamentally change everything would be if the FDA or whatever the regulatory environment is or entity makes the pathway to get interchangeability a little bit easier. That would be the one thing fundamentally that would change our ability to manage this category and ultimately save everybody money, including patients money in the long term. So we will end there. Again, thank you for submitting questions. Hopefully you found the presentations enjoyable and beneficial, and have a great day. Thank you.